Top-Bed Talk.
This next session we're going to jump right into. It's my great privilege to introduce the co-editors of the Journal of Perioperative Medicine, to be moderated by Dr. Mike Grocott. Dr. Clifford Coe and Dr. Lee Fleisher will be joining us in a few minutes to really share with us their thoughts and insights about the best manuscripts and literatures and things that we've learned in those last year in the space of perioperative medicine. So I'm going to pivot over to Dr. Mike Grocott.
I'm Mike Grocott. I'm an anaesthetist consultant attending in anaesthesia and critical care in the south of England and a professor of anaesthesia and critical care medicine. And I've had the pleasure and privilege of being one of the editors-in-chief of the Journal of Perioperative Medicine for the last 2 or 3 years. And I have with me Professor Clifford Coe.
Sure, thank you. First of all, thank you for inviting me. It's a privilege to speak here and be part of the journal. My name is Clifford Coe. I am a surgeon at UCLA School of Medicine, and I also work at the American College of Surgeons as the director of the Division of Research and Optimal Patient Care, which houses all the quality improvement and quality evaluation programs at the College of Surgeons.
So Cliff and I meet from time to time. Clearly at the moment we don't get to meet because of COVID, but actually the journal functions very much in a virtual way, and we each handle different elements of it, and the strategic bits we come together, typically actually on teleconferences or Zoom calls rather than face-to-face, but from time to time we get the pleasure of catching up with each other. And I was going to spend, before Lee joins us, I was just going to reflect a little bit on the history of the journal, which has been a long-standing evidence-based perioperative medicine EBPOM partner right since its introduction. So EBPOM's been around for more than 2 decades, as you know. Perioperative medicine was launched back in 2012. So first, the opening editorial and the first handful of articles came out electronically at that point. And unusually, certainly at that point, amongst the anesthesia and surgical journals, it's a journal that is free to view. So although typically, although not always, a fee, publication fee for the authors, although there are a lot of ways you can mitigate that. Some institutions don't have to pay it, for example. In terms of, it's an open access journal. And from very early on, because we were part of the Biomed Central stable, we were on PubMed. And since 2012, we published a whole host of different manuscripts. Now, Cliff and I are relatively late in this journey. The founding editors were Mark Hamilton and Monty Mython, who you will have met, one of the co-chairs of this meeting. I joined shortly after Lee. I think I joined in 2017. And we started feeling rather guilty that although we talk the talk of perioperative medicine, we weren't doing very well in our multidisciplinary approach. And so we approached Cliff, and we were really delighted when he came on board, which takes us right up to this year when we achieved, we've been on PubMed for a while, but when we achieved an impact factor. So I think we the three of us, building on the work of the founding editors-in-chief, are really very pleased that the journal has, as if you like, reached something like maturity, at least teenage years, if not adulthood, in terms of journals. And we have an impact factor just over 2.7, so a very respectable impact factor. And so we've selected 3 papers, but before we jump into those, I'm going to ask Cliff, and this is unscripted, but I'm intrigued, your reflections, Cliff, on firstly working with a couple of anaesthetists on the journal, and secondly, just the broader area of perioperative medicine and perioperative care and how things have changed over the last few years.
Yeah, I think that, well, thank you for that question. And it's an easy question to address because I think as we're moving forward and being able to evaluate better and measure better and have metrics and data, that we're seeing that individual people on the team are important, but the synergistic ability of the team itself is probably more important. And we're seeing that in clinical care in all different types of areas within perioperative medicine. We're seeing that in quality improvement itself of the quality improvement team. And I think that a journal like this that not only looks across the disciplines of surgery, anesthesia, and each of the parts of the team, but also across the phases of care. We have written a kind of a quality manual on kind of operative care, perioperative care. And so we think of it in 5 phases, from preoperative all the way to post-discharge and everything in between. And so having it multidisciplinary across the phases of care is a real step forward. And this journal really supports that. So I think that this journal is really probably from the leaders of it many years ago kind of had that insight and maybe ahead of its time. But I think now everyone is starting to recognize that the team the multidisciplinary team and across not just within the operating room or just the pre-op, but really expanding that across the phases of care of a patient's journey through an operation is really a priority.
Couldn't agree more. Now, you may have ducked through politeness the other part of my question, which was how you were finding working with a couple of anaesthetists. And the reason I asked that is not as a sort of surgeon anaesthetist contrast, but because from my perspective, it's very striking that we appear to have perspectives when we make the more strategic decisions, when we're selecting papers, for example, that are very aligned. But I'm intrigued to hear your thoughts on that.
Yeah, so I think that if there's obviously a different specialty, another specialty who we work the most with, it is with anesthesia. And yet, the proverbial curtain between us is there. But I guess in a theoretical sense, in a real sense, we need to kind of go across that curtain and understand the perspectives better. And working across that screen is clearly very important. And so my gains from doing this is really with you and Lee and the anesthesiologists that I work with in the clinical care, in the clinical setting, opening up and understanding that perspective and seeing what's important from a different perspective than what surgeons typically think is clearly really important. The aspect of highlighting and respecting the ideas has really opened the eyes of a lot of surgeons, myself and a lot of other surgeons, of what anesthesia really focuses in on and what we focus in on, and having that discussion of aligning those things to keep things patient-centered has really been a great personal lesson.
Very interesting. And I think, so we've noticed, perioperative medicine, the meetings and initially the journal was an overwhelming majority of the contributors and of the delegates in the meeting were team anesthesia. And certainly I would say the majority still are, but increasingly we are seeing delegates who are surgeons and delegates who are non-physicians and who are coming from other medical specialties. So I think from a personal perspective, it's very rewarding seeing the multidisciplinary words that are talked actually coming to life, and I think it's certainly for the benefit of our patients. So we've selected 3 papers. I think they're 3 really interesting papers just from the last 12 months, and it was a pretty hard selection. There's a lot of interesting material in there. Cliff, would you like to go first?
Sure. Going back for the past year or so in terms of the papers, there's a lot of diversity and high quality papers that we were choosing from, and I know that we had narrowed it down, and then we narrowed it down some more. And I think that we could have talked about almost any paper and spent a session on each of these because a lot of these papers are really important in their own right. But the paper that I chose is entitled Functional Performance and 30-Day Postoperative Mortality After Emergency Laparotomy, a retrospective multicenter observational cohort study of 1,084 patients. It was published or released in 2020 in Perioperative Medicine. And the first author is Mirjana Chahorik. I'm probably mispronouncing that. I apologize if I am. It's out of the Department of Anesthesia in Intensive Care Medicine, the University Hospital in Copenhagen, Denmark. And the aim of this study very directly is to evaluate whether a performance status score, and it's called ECOG, the Eastern Cooperative Oncology Group, the ECOG performance score was independently associated with mortality following high-risk emergency abdominal surgery. And I think that I was drawn to this because in the context of one of my daily job of working in the States with the NSQIP program, the National Surgical Quality Improvement Program, and that program is in hundreds of hospitals and even hospitals internationally. When a hospital first joins, we know that we're going to get a question that, all right, we need help once they get their data back. We need help with emergency operations because they tend to have more complications, more occurrences. And we need help with geriatric patients, elderly patients. And so this study really looks at kind of the combination of those two things, where they look at emergency operations, emergency abdominal operations, and they really make a point of talking about the elderly patients and frailty. And so they try to examine that and look at the risk adjustment and predictive scoring and what are the important variables as we take care of increasingly more geriatric patients, and we all have emergency operations that we're doing. So the methods of this paper, it was performed in Denmark. It was a multi-center retrospective observational study. And so they were very good in identifying, trying to identify apples and apples in terms of what the group is that they were studying. So it was abdominal emergency operations, intestinal obstruction, perforation, ischemia, bleeding. And it was done not just in one hospital, but 4 hospitals within the capital region of Denmark. And importantly, the data were collected from 2012, the whole year, January 1st to December 31st. And so this was a retrospective evaluation of that data from 2012. And as you'd expect, the data that was collected included demographics, clinical variables such as ASA score, labs, comorbidities, the indication for surgery, the sepsis score, because these were emergencies, abdominal emergencies, and then the ECOG status, or the Eastern Cooperative Oncology Group. So if you're if you deal with cancer patients, ECOG is one of the cooperative trials groups and does clinical trials funded by NCI, the National Cancer Institute here in the States. The ECOG score is very well known and very used to help assess cancer patients as they're undergoing treatments. And so these investigators used it to evaluate performance score. And the ECOG score goes from 0 to 4. 0 is fully active, perfect health, and 4 is completely disabled, cannot do self-care, and it's totally confined to a bed or a chair. And so it's a score that kind of addresses the whole spectrum of functional status and functional performance. And so that's what they use to evaluate the patients, in addition to the clinical demographics and anesthesia and surgical issues. And analyses, as you'd expect, descriptive analyses, univariate analyses, and probably the most helpful thing is the multivariate analysis. And if I could come to the results, let me first describe their cohort of 1,000 patients or so. The average age was 70, which is not uncommon for patients undergoing emergencies in this type of cohort, these types of studies. About 25%, a little over 25% of the cohort were 80 and above. And I think that for the clinical folks out there, that's, again, we are increasingly operating and taking care of patients in their 80s. It's almost might seem sometimes young when we see them in clinic or when we see them in the operating room. The ASA scores were collected, and 35% of ASA scores were 3, and 10% were 4 and 5. So that's the kind of the ASA classification for the cohort. Obviously, this group had a number of comorbidities. The top 3 comorbidities were hypertension, COPD, and ischemic heart disease. I don't think that's a surprise to anybody. The sepsis status, because that is obviously a predictor of outcomes. They used what was used in 2012, which included SIRS, sepsis, severe sepsis, and septic shock. 40% had no sepsis, 25% were unknown status, and a third of them had some level of sepsis that was recorded in the record. The ECOG status is really interesting. So 50% of the cohort were in perfect health. 30% had a slight decrement in functional status, and 20% had a moderate to severe decrement in their functional status. So that just describes, and I think that's not unreasonable for an emergency cohort, but it describes it well. As far as the univariate analysis, the following were associated with postoperative mortality. So age, as you'd expect, sepsis score, ECOG status, ASA score, cardiovascular comorbidity, albumin, and the indication for surgery, with obstruction being associated with mortality more than the other things. The multivariate analysis is where kind of the meat of this study is, and I'll just cut to the chase. The following variables were associated with 30-day postoperative mortality in this cohort. And they did it with a logistic regression. So you have odds ratios and the confidence interval that determine the statistical significance. But ASA 3 had an odds ratio of 5. ASA 4 and 5, they were lumped together as a group at an odds ratio of 17. The sepsis score was an independent risk of mortality at 30 days with an odds ratio of 2.6. But again, the meat of this study was looking at functional status through the ECOG score and using perfect health as the dummy variable or the referent variable. Each of the levels of ECOG, 1, 2, 3, and 4, had an increasing odds ratio. So slight decrement in functional status had an odds ratio of 1.7. in association with 30-day mortality. And then ECOG 2, 3, and 4 had the following odds ratios: 3, 4, and 6. And so ECOG 4, which was totally disabled and confined to bed or chair, had an odds ratio of 6 and was extremely significant. Now, when they went further and looked at 12-month mortality in a Kaplan-Meier evaluation, the 12-month mortality rate also scaled with each of the ECOG scores. And a lot of times we look at odds ratios and like, oh, that's very significant. But we don't really get the kind of quantitative numbers. And so here, these are the 12-month or the 1-year mortality rates of this cohort undergoing an operation by ECOG status. So in a perfectly healthy person of this cohort undergoing emergency operation, the 1-year mortality was 15%. And then for each of the subsequent ECOG levels, 1, 2, 3, and 4, the 1-year mortality was 40%, 54%, 74%, and 80%. So somebody totally disabled, again, confined to bed or chair, having this operation at 1 year, 80% mortality rate. I know a number of folks there, as Mike had said earlier, that are in anesthesia, and so use the ASA score a lot. And what was very interesting is that within each of the ASA levels, 2, 1, 2, 3, 4, ECOG, the ECOG functional status adds to it such that even within each of the ASA scores, there was increasing mortality for each of the ECOG levels in each of the ASA scores. In conclusion, this study found that the performance score using ECOG was independently associated with the postoperative 30-day mortality in this cohort of elderly patients undergoing high-risk emergency surgery, emergency abdominal surgery. If I could add, why did I really like this article and what I thought was the points of it? I have 3 points and then perhaps a comment. First, this paper contributes to our knowledge of adjustment and prediction. And so they look to see if there are additional factors. And when we look at, I know we do this in NSQIP all the time, but there's a lot of clinical registries out there. And what are the key factors that are going to help? And keeping things as parsimonious as possible. We want to get rid of factors that don't help, and we want to add in factors that do help and inform us clinically. And so they have found that in addition to what we typically have of demographics and clinical items, adding to it the functional status does add more information to the model and helps us explain better and predict better. The second piece is that it's clinically feasible. And so when we are dealing clinically with emergency patients in the emergency department and rushing to the operating room, lots of times we don't have a lot of time to do a huge evaluation. And so they talked a lot about feasibility of what instruments we have and can we do kind of right on the spot. And this, which was one of the reasons I think they chose the ECOG evaluation or the ECOG tool, is that it is doable and it is feasible to do in an emergency setting. They mention a lot of other evaluations that are 30 items. You have to use a grip strength a lot of times for frailty and whatnot. And so the clinical feasibility of translating it into the clinical setting is important. Finally, why do a study if it's not actionable and it's not going to change what we do? And so if this tool, this functional status, adding it to the prediction model, we get better, more precise prediction in terms of how the patient is doing and better evaluation of how the patient will do. And that's important, not so much in terms of a setting of maybe clinical care, because, again, emergency, there's no time for prehab or anything like that. But importantly, and I think that this is happening across everywhere, for decision making. A lot of times, balanced discussion, informed consent, advanced directives, identifying durable power of attorney for decision making if the person can't make a decision, and what those, getting more information for having that discussion prior to an operation. Because those, whether emergency or elective situation, these types of discussions need to be had as much as possible with the best data we have available. And if this is adding to that, that's a really important, actionable result of this paper. I think that the one comment I have, or at least one of the comments I have, is that they make a point of evaluating frailty with this performance status score. And at the College of Surgeons, we just released a program that is called a quality improvement program called the Geriatric Surgery Verification Program, or GSV. And in that, we worked with a number of stakeholders, anesthesia, surgery, geriatricians, gerontologists, patient groups, and so forth, and looking at the idea of frailty, because how can we get this frailty evaluation done well when we take care of patients, especially in the elective setting where we might have time to do prehab and other things. And I think that the collective feeling of all these experts and specialists is that frailty is a multi-component item. And clearly, functional independence or dependence and functional performance is a part of frailty, but it's by no means all of it. Things like mood, continence, nutrition, medications, polypharmacy, social support, cognition. I know that Lee has been working in his brain health initiative and cognition is clearly a huge part of it. So frailty is the functional status is important in frailty, but there's other things that make frailty a much larger, probably item than just the functional part. But function is clearly important, and their work has shown that function does add to our knowledge base of prediction and adjustment of these patients. And it's something that we should be thinking about as we're taking care of this group of patients for emergencies, as well as in the geriatric population. Thank you.
Cliff, great job. Wonderful summary. And I think importantly, you brought out the fact that so whilst, like all journal editors, we love randomized controlled trials with an actionable result, some of these observational studies are really valuable in the way they can inform practice, particularly in terms of providing incremental improvements and information to guide, for example, shared decision making. Now, so Lee, welcome. If you
Thank
give
you.
the audience a brief introduction. I know you have many titles, but the key ones.
Well, I was chair. I am professor of anesthesiology and former chair of anesthesiology at the University of Pennsylvania. I am currently the chief medical officer and the director of the Center for Clinical Standards and Quality for the Centers for Medicare and Medicaid Services, which is responsible for the quality of care for 147 million beneficiaries, according to the job description I have. But I am not speaking today here as a CMS employee or in government service. I have to say that, or I would have needed clearance, and I didn't get it for this. I'm speaking purely as an anesthesiologist. And most importantly, I still give anesthesia twice a month. So Fantastic. The fun part of my job.
And I know that's a really important job, but you can reassure Cliff and I that your editor-in-chief of Perioperative Medicine is at the top of your business card, isn't it?
It is on my job description, and I did continue it, given the other things I'm supposed to be doing, which is overseeing nursing homes in the U.S. during the COVID crisis.
Goodness.
This still was a high priority.
So, Lee, for lots of reasons, technical and otherwise, we're a little bit short of time. So are you happy? So you and I will probably do a relatively shorter vignettes of the papers. Are you happy to go ahead and share the paper you selected?
Sure. Randomized trial of non-invasive cardiac output monitoring to guide hemodynamic optimization in high-risk patients undergoing urgent surgical repair of proximal femoral fractures. And it's a randomized trial and had a trial number. And clearly, we all know as perioperative physicians the high risk of patients who are undergoing hip fractures between 20 and 60%. So they even went further and used the, I believe it's the Nottingham Hip Fracture Score, and selected a very high-risk subset of patients undergoing hip fracture. And they randomized individuals to fluid optimization using ClearSight. But in addition, and importantly, they added that they maintained blood pressure within 30% of baseline. And they used infusions of phenylephrine or metiraminol. So they made sure that they had the two together, because they said potentially it's all about the fluid alone couldn't do it. And by looking at an enriched population, what was important to them is that they thought they would have a 60% baseline rate of complications, which we'll get back to. But essentially, they randomized 121 patients allocated to the intervention and 120 to the standard care. And they lost to, importantly, that in the intervention group, there were 18 equipment failures, clinician override in 2, and incomplete in 1. So 21 patients did not receive the allocated intervention out of 121 patients. In brief, the primary outcome, what they saw was that 46% of the patients in the intervention group had a composite of a postoperative complication compared to 51% in the control group. So the odds ratio of 0.82, non-significant. Now, they actually predicted a 40% complication rate in the intervention group, but a 60% in the control, and we can come back to that later. When they went per protocol analysis, that the odds ratio was a little better. It was the control group of 51 versus 43%, so you're getting closer to the predicted event rate with an odds ratio of 0.73, but the confidence intervals, again, were 0.43 to 1.24. And when they looked at the mean length of stay, which was a secondary outcome, the mean length of stay in the intervention group was 23.2 days and 18 days. The control group was 23.2 and the mean length of stay was 18.9. It really was, the p-value was 0.053. So that shorter length of stay, realizing that that's a signal for complications, that there are two signals here without absolute outcome. No difference in mortality, not to be expected because of the sample size. But importantly, when they looked at the intervention group, spent less time in an absolute map of 70, 65, and 60, but they had a difference in the amount of fluids given, but they didn't have a difference in the amount of patients with very low blood pressure. When they did the updated meta-analysis, there was no significant difference in mortality, not to be expected, but the difference in morbidity from the 4 studies was 0.82, which actually confidence interval of 0.69 to 0.99, so just met significance with an 18% decrease. So as you think about it, we always like randomized trials. It took a meta-analysis of lots of small randomized trials to suggest that there was benefit. But as we know from our friends who like to do large pragmatic trials, this may or may not wash out as we do larger samples. But they also argued with all the other interventions that the mortality in the control group was actually less than the 60%. It was in the, as I said, 51%. So I think this is an important trial. There's enough of a signal that they correctly asked for more large-scale trials. And importantly, in this paper, they identified that they really didn't get great separation in the amount of hypotension between the two groups, and that really the protocol would need to address that in any future state. So again, an excellent randomized trial, didn't give a definitive answer, gave us some thought of what the baseline rate should be when we're doing future randomized trials, and certainly justifies continuing to look at this important question.
Lee, thank you for a very concise summary. Monty's joined us, which I suspect means we're moving on to the next session. It leaves me about 60 seconds, if that, to summarise my study, which I'll do very quickly. And this one I really chose because it highlights the extraordinary diversity of perioperative research. And when I just give you the title and the authors, you'll get what I mean. So this is The Effect of Virtual Reality Technology on Preoperative Anxiety in Children, a Solomon 4-group randomized clinical trial, and it's from a group of authors led by Dr. Degan from Kermanshah in Iran. So international reach of the journal. And what most intrigued me about this, I mean, not terribly surprisingly, I'll cut to the punchline, the virtual reality technology did help with the kids' anxiety, but the sophistication of the trial design. So in these psychological type interventions where you need a you're worried that pre-test measures, so if you're looking for a change in an anxiety state, for example, but the simple measurement of the pre-test may either worsen anxiety or ameliorate anxiety, they have this complex design with two groups. Two groups have an intervention, two groups have a control, and within each of those, one gets a pre-test and post-test, and one gets a post-test. And by separating those out, you can remove the effects of pre-test measures of anxiety, for example. So it's not a design I've come across in the type of research I do. I thought it was a very smart design to answer an important question. I'm obliged, sadly, we're out of time, so I'm obliged to draw that to a close. But thank you so much for spending the time presenting those papers. Cliff, thank you. Lee, thank you so much.
Thanks, Cliff.
See you. Take care.
Top Med Talk. Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.